Yeah, hey David. Let me start the recording and let me change the screen here. Let's see, that's me. Oh, no, one more. There we go.
Okay. So can people see an abnormal chest radiograph?
Very abnormal.
Yeah.
So Chuck Roman shared this case of a very dilated esophagus full of a lot of debris with a nice air debris level here. And this is a case of horrible achalasia with lots of stuff in this very dilated esophagus, which tapers down. And there's no mass at the bottom here, so this is not a case of obstruction by carcinoma. And the degree of dilation is also a little out of keeping with obstruction from a cancer. So this was a case of achalasia. Now there are some GI studies that show very disorganized peristalsis and not much propulsion, but I will have to take steps to anonymize those, so I couldn't show those today because I have to cut off some name information that's at the top. So abnormal esophagus here, a case of tremendous dilation by very big achalasia. And pull up the SAG. So abnormal esophagus, I'm glad it's not my esophagus. So, okay, and then this is a person who has a dilated central airway. So notice the little corrugation here and the dilation of the trachea and bronchi. So this bronchial caliber here makes a, it doesn't leap out at you, but this bronchus is dilated. It's about the size of a normal trachea, and the right bronchus is similarly dilated. And there's a bunch of stuff in the bases here. And this is a case that we're calling Mounier-Kuhn syndrome, dilated trachea and bronchi. So tracheobronchomegaly, very nice irregularity here. I think there's sort of sacculations between the cartilages. The tissue seems to bulge out, and you get this rippling effect as you scroll through the trachea. And then the proximal branches within the lungs are involved on both sides too. So this extends beyond the most central bronchi into at least probably segmental bronchi here. And the person, I think, had some difficulties with aspiration. So this is, and then down here we've got this, a lot of stuff down here. So I think this is probably a result of aspiration down here leading to progressive dilation. There seems to be an echo. Okay, so we're calling it Mounier-Kuhn. And on a series of chest radiographs that go back several years, there's been variable amount of stuff in the lung bases. So I don't know whether there's a primary bronchial problem in the bases or whether this is secondary to secretions pooling down there, and then,
or a combination of both.
A combination. So, and this is a young person, I think in her 20s. So I like, for the diagnosis of Mounier-Kuhn, I like it to be congenital, to date from childhood. A lot of tracheobronchomegaly that could be secondary to, say, even COPD or lung transplantation with fibrosis pulling on the mediastinum, or chronic inflammation gets called Mounier-Kuhn, but I think it should be a congenital disease. I think this one is congenital. And, there are no specific pathologic findings for Mounier-Kuhn or for Williams-Campbell. And so these diagnoses are rather squishy. And you just have to take the literature with a grain of salt about somebody's claiming it to have one of those names on it. So I think this one is a reasonable candidate for Mounier-Kuhn, given the central involvement.
Yeah, I agree, David. I think of it as sort of the end result of a variety of insults or predispositions in the lung that lead to breakdown of the normal airway integrity, and you get that scalloping that you nicely pointed out. I mean, I've seen cases where it's not truly, the diameter isn't that great, but the contours are quite abnormal and varying degrees of bronchiectasis. And when I think it as congenital, I don't think you're born with it, but I think some causes, maybe connective tissue abnormalities where they're lax or there's deficiencies in smooth muscle.
And then it develops from there, right?
Right. But I've also seen in people with recurrent infections who get bronchiectasis who then get sort of an upstream phenomenon.
Okay.
Yeah, I think I like the fact that the trachea is more lemon-shaped, not spherical enlargement, as David said, because that's usually what you see with COPD or patients with fibrosis.
Mm-hmm. Okay, and then here's a woman who has an abnormal aorta. You can see that she's got a lot of thickening here. She's fairly young. I think she's 30, and she does have, her aorta is dilated at this point. It's more dilated than it was back in 2006. So in 2006, she had fairly normal CTs. She did have these breast replacements. She did have a carcinoma. I don't know, there was both sides or one side, and they did the other prophylactically or something like that. But there's a history of breast cancer. And then this aortic abnormality continues down in through the abdomen with wall thickening and some degree of dilation. And so people were talking about IgG4 disease and a whole bunch of things, and giant cell and stuff like that. So one of the considerations is that this is Erdheim-Chester. Now, there are no halos around the kidneys, which would be pretty good for Erdheim-Chester. We have seen people, before we had a case here, of primarily aortic disease from Erdheim-Chester. So that's definitely on the list. And there is this study of, I don't have any plain films of long bones, but here is let me show you from this localization thing here. There is this sclerosis of the bones, and there's a scout view here, I think, if I can find it, there it is. It just flipped by me. See if I can find that scout view for you guys. I should have isolated. There we go. So on this scout view, you can see that there is this symmetrical sclerosis of bones. I think that this pseudo plain film finding here, combined with that aortic disease, points strongly toward Erdheim-Chester. Now we don't have a biopsy to prove that, but I think that's a very reasonable presumption given this pattern of long bone sclerosis. This is pretty distinctive. And there's about, I think Erdheim-Chester is about the only thing that does this. So
Yeah, I guess I would have thought without the bones, I would have just said Takayasu most likely, but it certainly that doesn't affect the bones really like that.
Key.
Right. Okay. And this person's been, a lot of these images came from the NIH. So, they have a registry of Erdheim-Chester, and they've done a lot of work on it. So they've coordinated a lot of stuff. So she's been to the Mecca for Erdheim-Chester. She's now being treated here, and they're hesitating to treat her for Erdheim-Chester with specific therapy for that, short of a definitive diagnosis. But I think they're working on some other leads that might help them get to that point. Okay, so I've shown you abnormalities of 3 tubes in the body, a vascular tube, the aorta, and the esophagus, and the airway. So this is, as the surfers used to say, as a term of approbation in Southern California, tubular man, tubular. You guys don't remember that?
I remember that.
You do? Okay, good.
Well, it was perpetuated into the little right. Into the 80s and 90s.
Right.
So.
Yeah, that was my prime. So. All right. Thanks, guys.
All right. Travis, you want me to go or you want to go?
Either way.
All right, I'll go quickly. Let's see. So this is a case. You guys, let's see. You should see a. We don't need to do that. Let's see. Close that down. Yeah. So this is a case sent to me by Tasneem Lalani, who was at UW Seattle years ago. Was attending of mine in abdominal imaging. This is a case of sarcoid. You can see there's nice lymphadenopathy. These are movie files, but what's really cool though is check out the aorta. and the branch vessels. There's clearly an aortitis going on, and I think we can see that further down. And so this is a nice companion case for David's. We don't see anything else. And then I do have a PET CT, or the PET, I guess. So it's a sagittal PET image here, but you can see there's FDG uptake both in the lymph nodes, but look at all the uptake in the aortic wall. So this is a case of sarcoidosis with, in addition to lymphadenopathy causing aortitis. And there are rare case reports. There are case reports of it, not anything large. I've never seen it before, but a nice example of that. I don't know if either of you have ever seen sarcoid aortitis.
Is it proven?
I believe it is. I don't know. I don't think they biopsied the aorta, but it's
because I guess the question is, we had a recent case where there was sarcoid and there was also organizing pneumonia that looked distinct. And is it just that sarcoid is so common that it just coincides with other diagnoses?
Yeah, it's an older patient, if I recall, so it wouldn't be a Takayasu. It would have to be a giant cell. But
yeah,
I mean, their working diagnosis is this is sarcoid, and it is reported in the literature. It does occur.
Yeah.
Yeah, I don't think they're going to want to biopsy the aorta if they can avoid it. But yeah, it's at least a nice case of aortitis either way.
Wow.
But yeah, it's kind of cool. Okay. So here are my cases. So this is an interesting case. So this is a 68-year-old patient, female patient, who presented with cough and shortness of breath, never smoker, and had this radiograph. And you can see there's upper lobe collapse with a mass, and there's diffuse tiny nodules, and there's pleural effusion on the right. Let's see, the CT scan at that time shows mass, lymphadenopathy, pleural effusion, pleural tumor. And if we switch to the lung windows, you can see there's just diffuse tiny lung nodules. So a nice case of metastatic lung cancer and a non-smoker, never smoker. So this was biopsied, it's adenocarcinoma, and it was EGFR mutation positive, which we expect to see more often in females, Asians, and non-smokers or never smokers. And I thought it was a cool case because I'm going to show you so the patient was put on an EGFR mutation inhibitor, an EGFR receptor inhibitor. It's osimertinib, I think, is this particular one. Erlotinib is another one we see a lot. And you can see this dramatic improvement. They treated pleural effusion with a catheter, but you can see the mass, the miliary nodules are, pretty much gone. The lymphadenopathy melted away. And here's the follow-up CT. So here's the CT after being on this EGFR inhibitor. So there's the mass, but you see the lymph nodes are back to normal. There's really not much pleural disease left. There's some pleural thickening. There's clearly going to be some tumor there. But if you look at the lungs, there's just been there's a few little nodules here and there, but it's just a striking response to therapy. And I've seen a few of these patients, they do quite well for a prolonged period of time. You think metastatic lung cancer has a 5-year survival rate of less than 1%, and that's on old data. But I think we're going to see more of these in patients with these sort of good types of mutations where there's decent therapy. So it just melts away. But eventually, of course, you select out the mutants, and then you get recurrence. But I've seen them hold steady for a couple years, a couple of them. So just a striking response to that. All right, this was an interesting case. It was kind of a hard case without getting all the information together. Let me see if I can find it. So this patient has a history of a carcinoid tumor. That's what I'm blanking on my term here. Had a carcinoid tumor and was being staged. The carcinoid is hiding down here in the left lower lobe. There's a mass right down in here. And had a mediastinoscopy, and shortly after mediastinoscopy developed, I think this is the right CT, yeah, developed some subacute gas and some chest pain. And you can see there's all this gas here, and you see there's pneumomediastinum. There's trachea collapse, she's expiratory, but there's gas all around the area. And then in the subcarinal space, there's gas. And So they were at first concerned about an airway injury, but when they got some of the frozen sections back on the lymph nodes they biopsied. One of the things came back as epithelium, and at first they thought it was airway, but then they decided it was actually esophageal. So the concern is there was a biopsy of an esophageal diverticulum. And so I'm going to show you some images from an esophagram. And so here we go. So this was done after the surgery, and you can see some motility issues, but then right there you see it spill out, and I'll show you another sequence. So then here's another swallow, and you can see there's some motility, but as they scroll down, you see right there it spills out. So it looks like there's a little neck there, sort of right at the subcarinal space. And so the concern was there a diverticulum hiding in the big lymph node bundle that was, when you do a mediastinoscopy, it's a very small space with a very hard to see. And so it wasn't until we found, and I don't have the outside old CT, but there was an old CT that was from a few months before that showed no diverticulum. So what had happened is this is a perforated esophagus, but it formed because when they do the mediastinoscopy, they take out the whole packet of lymph nodes. It leaves a space in that region. So it created a space for the contrast to pull and then pool. And then we did a subsequent CT, which I believe was this one here. Yeah, there you can see. So on this one, you can see there's some contrast pooling up in there, but this is the space that was created during the mediastinoscopy. They took out all these lymph node packets when they were in there, and then it just sort of dissected along there. And then the other thing is you'll notice this pleural effusion is sort of becoming convex that way. So concerned this was after a few days that they're developing empyema. And so they actually went in there and cleaned this out. There was some purulent fluid in there and put a stent across it. Let's see if I can find that radiograph. I must have not saved the radiograph, but anyway, they just stented across this and cleared this pleural collection out, and all was well. But if you just look at the barium images, it looks like a nice diverticulum. And even the GI radiologists were a little confused because without access to the previous imaging, it looks like just a diverticulum, sort of a Pulsion diverticulum where you'd expect to see one, or because there was no scar around it, and some motility. So a little complication there. And then this last case is kind of cool. So this is a 63-year-old with a history of protein S deficiency, known PE in the past, presented with chest pain, and was diagnosed with a myocardial infarction based on enzymes in an EKG, so a STEMI. Went to the cath lab, and I'll show you the cardiac MRI, and got treated for an RCA infarct. You'll see that there's a stent in the right coronary artery.
Oh.
But right here on the aortic valve, you can see there's this blob. And then the other interesting finding is you'll see there's webs in the right lower lobe. You got some webs there, and you've got some webs in the left lower lobe as well. So remnant of pulmonary embolism. So of course with protein, and then some pretty chunky bronchial arteries. So a patient with protein S deficiency, of course, is prone to forming clot. You see there was a little bit of plaque, but not a huge burden of plaque. So they did do a cardiac MRI, which, if I can get the right, here's the, just shows, you can see that the inferior wall is a little hypokinetic. I'll put it on a cine, but you can see it's hypokinetic there. And then I'll show you the delayed enhancement. Here we go. That shows it nicely. Yeah, right there. You can see the inferior wall right there. And then on this image, let me do the short axis. Right there, you can see nice thing there. So it's both on the pulmonary arterial side and the systemic arterial side. And that deed was a thrombus on the right atrium. So this patient had been on anticoagulation for a long time. So even with that, they're still prone to thrombosis. And not just pulmonary embolism, but also systemic arterial involvement as well.
So Jeff, that thrombus was on the aortic valve?
It was,
right?
Indeed. And I think you can see it on the cardiac MR too, right? There it is right there.
Yeah, it's just sitting in the right sinus.
Yeah.
So she probably didn't have actual coronary artery disease, that she had an obstruction from that.
Exactly. It was probably,
Wow.
yeah, because if you looked at the amount of You can see
Yeah, because
he doesn't have a lot of plaque. He's got minimal disease in the LAD. But yeah, just
and
right.
the fact that it's on the right side is even worse because of their pulmonary hypertension from their chronic thromboembolic disease. So
Yeah.
that right coronary is working even harder with the RV.
Yeah, look at that. And you got some
Wow.
nice smoke artifact in here too, just for you, Travis.
Wow.
Yeah, so and these can be really tough to manage. And warfarin is the standard, but he was on one of the newer agents. But even with anticoagulation therapy, this can still happen. But it's a nice case for a couple reasons. It can show, again, satisfaction of search could get you into trouble if you're only paying attention to the pulmonary arteries or the coronaries. Also, you get a nice RCA territory infarct on the cardiac MR, and then of course just the kind of complications of this. So, all right. So that is what I have this week. I can turn it over to you now, Travis.
Okay. So this case, you probably remember from a few weeks ago. This is the patient who came into the VA and was diagnosed with a left upper lobe pneumonia, came back less than a month later, and the left upper lobe had flipped. And so he had torsion, which we thought was from the pneumonia. And this is, I'll show you the CT, the sagittal. So that left lower lobe the left upper lobe is socked in. So it still looks like pneumonia. Certainly pneumonia can hang around for a month. And I talked to the surgeon. So he actually did this thoracoscopically, where he went in and detorsed the lung and then plicated it. And the surprise was he took a little snippet of lung for the plication, and the path a few days later came back as adenocarcinoma. And on subsequent radiographs, his lung has not improved at all. This is just a representative one, but he's looked like this since then. And so it's probable that this is all adenocarcinoma, like a pneumonic or mucinous adenocarcinoma throughout the entire left upper lobe rather than pneumonia. Since I've got more recent studies even from this week where that left upper lobe is totally unchanged. So it's still torsion, but in this case, actually due to cancer rather than pneumonia. So, but Jeff, you had the one that I showed as a companion that was pneumonia. So now we can add cancer to our list of differential causes of this, which of course it has been reported as a cause as well. All right, so back up to the top here. A few of these have interesting radiographs. This is a 69-year-old man who was presenting with weight loss, dyspnea, gradual worsening of lower extremity, swelling, abdominal bloating, etc. And let's see if I can unsync these. And you can see that he's got an interesting finding when you zoom in on the heart, or at least on the mediastinum. He's got this very coarse calcification, and you can see it on the lateral view as well. And it's kind of odd. It's certainly looks like part of it may be curvilinear along the pericardium. So you might think that he could have constriction. Certainly that would fit with the worsening lower extremity edema and whatnot. Actually, that was outside, wasn't commented on. They did an abdomen and pelvis CT first, and you will see this is not, this is not just pericardial calcification, but there's this huge mass, for lack of a better term, that's partially calcified, coarsely calcified. And what's interesting is it's hard to really say where this is, if it's in the pericardium, if it's in the mediastinum surrounding the pericardium. I actually was curious about the fact that some of this was along the cruce here, the left diaphragmatic cruce. You can see all the edema and whatnot in his belly. And so when they showed this to me, it's encasing the IVC here. Certainly you think of tumor. I wasn't sure this couldn't be some weird form of tuberculosis or some granulomatous infection, given that it was a patient that was from Mexico and it had TB in the past. So we did a CT though of the chest the next day, and I think this kind of removed all doubt. He had a few nasty looking lymph nodes. You can see anterior mediastinum and then left paratracheal region here. And it was still hard to really, guess where this was coming from. I thought maybe it could be like some sort of mesothelioma from his pericardium, some sort of weird sarcoma. They didn't really need to do an MR, but they did it anyway. And you'll see on the cines that it looks like it's just exerting mass effect from underneath the heart. So we did a biopsy of that anterior mediastinal lymph node, and this came back as an undifferentiated pleomorphic sarcoma. And so presumably this was the primary and that had metastasized throughout his mediastinum. And unfortunately, he didn't really have any good options. They put him on Pembro as just a off-label, but as a charity case. But he ended up passing away a couple weeks ago, so they weren't able to really do anything with this. So just, sometimes we see sarcomas pop up, and they're often weird and nasty tumors like that, big and ugly. I don't know. What do you guys think that is rising from? Any thoughts?
I don't know. I've seen a few cases like this too. You just get a metastasis, but it takes up. They're so big, they're solitary that it's hard to sort out. Is it lung or pleura? I wonder.
Yeah.
Yours looks more mediastinal.
Yeah. That's why either mediastinum or pericardium, I think. So,
yeah.
Yeah, but he didn't have much of a pericardial effusion, but big ugly sarcoma. Now this is one that I've titled as the most useful rib series ever. I say that in a joking way. Jeff is laughing because we both write for the appropriateness criteria. One of them is on rib fractures that I've authored, and of course there's really no data to use rib series for the evaluation of rib fracture. But I think in this case it is very helpful. Now there's a finding on this radiograph. This patient, you can see on the PA view, there's maybe a little increased opacity over the right hilum, and laterally you can see that there's this focus of consolidation anteriorly. Well, they did a rib series at the same time, and I'll show it just because you can see they put the BB right over there. So this person had anterior pleuritic chest pain, and of course no history of trauma. So you can see this on every view, and I think this is the best one that lays it out, this oblique view, and you can clearly see there's this nodular area of consolidation. Young patient, so we didn't know if it was pneumonia or if this was a small infarct. That was really our differential, but I thought this rib series was very useful in that regard. And of course, on follow-up radiograph after antibiotics, they did a lower extremity Doppler as well, which was negative. So they thought this was just a focus of infection, and you can see it's gone. So yeah, again, rib series don't really have much utility since diagnosing minor rib fractures on them doesn't really improve patients' outcome versus just supportive care, even if you miss a rib fracture. But in this case, it was a nice, nice oblique view to see this little focus of presumed pneumonia. This is one where you'll see this is a very young patient, and this is something that fools us every once in a while. This patient has a little bit of consolidation in the lower lobes, and there's some volume loss here. They already have a PIC in place, so some of this may be atelectasis, maybe a little bit of aspiration, but you can also see that they have innumerable tiny little nodules studding the pleura in a random distribution. So it looks like some sort of miliary spread of something. And you can see they have big bulky adenopathy in the lymph nodes. But what's interesting in this case is that they have this destructive lesion of the right scapula. You can see a portion of it being eaten away here. And they had at least a couple of ribs and vertebral bodies. You can see the T1 vertebral body. This patient actually came in with cervical spine pain, and this was presumptive metastatic disease. Now, the patient didn't have a known primary, and they went to do a surgical biopsy of one of these lymph nodes, and it turned out that this was all cocci. So this was disseminated coccidioidomycosis. And I know I've shown a couple of other cases over the last couple of years, very similar, but especially in young patients, or patients that don't have a known primary cancer, it's something that I frequently forget to include in a differential diagnosis, but I've remembered more as of late because it can mimic cancer as it does in this case.
So Travis, is this,
yes.
this female, does she have any sort of exotic origin, such as Filipino-ness or anything like that? Or
No, she's just from the Central Valley. So
yes, okay. Well, there's a ton of
I,
Filipinos in the Central Valley.
yeah, right. I don't know her ethnicity. I know that, yeah, a lot of the Hispanics have increased susceptibility. Are Filipinos particularly at risk of disseminated infection, or?
Filipinos are particular risk of dissemination, but dark-skinned people in general, and includes black people too. So
Okay.
you're more susceptible, and Filipinos in particular, I think.
Yeah, and I don't remember that case in her. I mean, we've certainly seen that, a lot of Caucasians with cocci pneumonia, but I think you're right that it's more often that they get the disseminated, nastier forms where they end up with meningitis and long chronic symptoms.
Well, I've seen several Mexicans here that have what's thought to be TB, and it's cocci with lymphadenopathy and a lot of bone involvement. Psoas abscesses, spinal discitis and psoas abscesses and things.
Now, I'll let you guys look at this radiograph and see if anyone wants to comment on anything. This was just a portable I saw. It's more of just a curiosity and a fun little finding.
Is that a renal failure patient? The bones look funny, and looks like a venous stent.
Yes, they have been on dialysis. I don't know if they're currently on dialysis or not, but actually that was what I thought this was going to be at first.
Yeah,
and
it looks like there's a bump above the aortic arch.
Yep, exactly. So I saw that, and I assumed this was just going to be some tortuous vein, or something else.
And just sort of the upper paraspinal region's abnormal.
Right. Yeah, there's almost like a little rightward deviation of the trachea.
Yeah, I can't tell if the head's tilted or something.
Yeah. So I'll show you, but that is the finding, and exactly when I saw that and that, I thought this was going to be just that venous. It actually turns out that she has a left subclavian artery aneurysm that's partially thrombosed right here. And I think that, Jeff, your observation of the rest of this is very astute as well, because it's pushing things out of the way. And I am suspecting, my theory is that this is from a prior dialysis fistula in that left upper extremity that probably caused it to enlarge. But anyway, her left subclavian, or her left axillary and brachial arteries have been chronically occluded. But I just thought this was a nice radiographic finding. Let's see, I'll do a coronal here. If that'll actually work, we'll see. No, I guess not. No, it's not going to let me. Maybe it will. But yeah, so that's the little bump right there that we see. And then I think it's just the fact that it's dilated the whole way up is kind of what's displacing the trachea to the right. And
notice that she's got erosions of her distal clavicle near the AC joint. It's very fuzzy.
On the CT, it wasn't included on the radiograph.
Right.
Yeah. And
then I'll bet you that can you do a sagittal of the T-spine? Let's look for any striped marshmallow-like vertebral bodies.
You can almost see a little bit of rugger jersey even on coronal there. Let's see. Yeah, it's more just they're really dense. But yeah, certainly findings of renal osteodystrophy.
Very cool.
Yeah. So, but I thought it's a cute little subclavian artery aneurysm.
Yeah, that's cool.
And then another, we see this often, just more clues, because pneumomediastinum can be subtle. In this case, I don't think it's really that subtle. Along the trachea, you can see the right tracheal wall pretty distinctly, especially lower down. And of course, one of the keys is you see the inferior portion of the left main stem bronchus. You see this kind of tracheal wriggler sign where you see both sides. But I thought this was a good example of a continuous diaphragm sign too, which we occasionally see with the air along the inferior margin of the heart. And the lateral's not all that great, but you can see a little bit of it sneaking up around the heart here. And of course, you can see the anterior trachea. You can see the ascending aorta with air around them as well.
Air around the left pulmonary artery too.
And then air, what did you say, David?
I thought there was air around the left pulmonary artery on the lateral.
Yeah, right here.
Uh-huh.
Yeah. Yeah, no ring around the artery sign as I showed a couple weeks ago on the right pulmonary artery though. And so, but you'll see this is just that air that's inferior to the heart. It's not in the pericardial space, it's in the mediastinum. And I guess a little this you would say is along the inferior pulmonary ligament right in here.
No, that's actually the phrenic nerve.
Is that the phrenic nerve right here? Okay.
It was going out there. Right.
So this is the phrenic nerve reflection, and then the inferior pulmonary ligament would be, oh, is it? It's more posterior, like in here.
Right.
Okay.
Yeah.
Yeah, those are still landmarks that I find confusing down here.
Okay. Now, you know, was there any error over the lung at the right apex? Because I thought I was seeing a little pleural line up there. No, we don't have the pseudopneumothorax.
Right, the extrapleural air.
Right.
No. So.
Okay, way cool.
And I think, Jeff, I've got one more, but I think I'm going to save it for next week when more people are here, because
yeah, that's fine. We can end early.
It's quite a case.
All right.
So that is it for me then.
All right. Well, we will end a little early today. Thanks for the great cases.
Thank you.
Talk to you next week.